So the biggest issue for myelofibrosis undergoing stem cell transplantation is what do we do after transplantation? And for myelofibrosis, which is a clonal myeloproliferative neoplasm, we have the fortune that we have 3 driver mutations: JAK2, MPL, and calreticulin. And for this, there are PCRs, quantitative or qualitative PCRs, depending on the academic center. And what we do as a standard of care for almost 15 years now is we follow up all of these patients undergoing stem cell transplantation on certain time points, day 30, day 100, day 180, and 1 year after transplantation, for the driver mutation, so the mutation clearance, the mutation burden. And what we saw now in this huge data set of more than 300 patients with a follow-up of more than 10 years is that patients who got rid of the mutation, for the driver mutation, especially JAK2, they had a better outcome after transplantation. And this was particularly true for day 30 after transplantation. So day 30 after transplantation, doing the PCR for these driver mutations is essential to understand whether patients will relapse or will die from that disease. The other important note that we really identified for the first time was that calreticulin and MPL cleared their mutation much earlier and much faster than JAK2, which explains the onset better prognosis for these patients. But on the other hand, if these patients with calreticulin and MPL also were positive, so had still mutation on day 30 after transplantation, they had worse outcome. So doing these methodologies after transplantation is of utmost importance to really help patients identifying who relapse or who don't relapse. So this will be hopefully the standard of care, what we want to share with the community, that everyone needs to do that.